Hey, baddies.
Hello, everyone. You guys know I always start this out with it is Friday's Eve. It's Thursday. I know you're seeing us again, second time in 1 month. Sometimes we try to surprise you guys and come on here. And tonight, I'm really excited for the conversation. I know Jasmine is as well. This will be our second shared decision webinar, and definitely excited to get some more perspectives and see what everybody has to say. What about you, Jasmine?
Absolutely. So, like Marissa said, this is our second shared decision-making webinar. We'll probably do this every year because it was a really big hit last year. But last year, like, we were kind of pushed into it, it was our friends at Fred Hetch were like, we need to do this. And we made it happen, but it was really just us. So just like we've done as we've grown in other areas, we've tried to make sure that we've included baddie perspective and the expert perspective, and we're going to have the chance to do that tonight. So I'm excited for that.
Yes, I am. And because we always forget, we'll definitely introduce ourselves. My name is Marissa Thomas, one of the the good half that we have here at For the Rest of Us. Jasmine is my work wife. We are the ones that run For the Rest of Us behind the scenes, doing all this fabulous work that you guys are seeing. And so I'm a breast cancer survivor myself. I was diagnosed at the age of 35. And then I will let Jasmine introduce herself as well.
Yeah, you called yourself the good half, so I'll be bad cop.
No, I didn't mean that. I didn't mean the good half. I was meaning like,
I'm bad cop. They know it in meetings. They know it. But no, I'm Jasmine. I was diagnosed at 26.
Ooh, I'm not sure if Jasmine is frozen for you guys. She's frozen for me. Is she frozen for everybody?
For the rest of us. Am I back?
Yeah, you are back.
Mom.
Sometimes we have these moments sometimes.
Look, like in 5 minutes before, and I'm like, my camera won't work. Yeah, the fun. But yeah, we built this only 2 years ago, and we've grown a lot. And it's exciting. We are the first breast cancer community that's inclusive to all women of color. We've done our best to be diverse on our panels tonight. And so we really hope to dive into some great conversation, and we're really excited for it.
Yes. And I believe our first topic, what we're going to speak about today, is breast surgery. Is that right, Jasmine?
Yes. Our first topic is breast surgery. We're going to bring on Dr. Solange Cox, who is going to be our breast surgeon topic expert. And then we also have some baddies to join us in the conversation. So go ahead and bring them up. Let's welcome Dr. Solange Cox to the screen.
Hello.
Hello.
Hi. Hello, everyone.
How are you?
I am doing well. How are you?
We're doing good.
Good. I'm sorry. I was trying to get into the chat for a while, and so finally let me in.
I know sometimes if you're like logging in from your work destination, there's always like a firewall.
Just
because that protects
battle that a little bit, but that's okay. Awesome.
It looks like our backstage is full. Everyone's on here a little early. So if you're on a little early for your segment, we're going to ask you to come back 15 minutes before so we can get all the guests in for the segment. So we only have 10 people on stage. And we have like 17 that are going to be on here tonight. Okay, so they're dropping off. All righty. And now we're going to bring on stage our baddie ambassador.
So our baddie ambassadors that we have is Jamel Singleton and Vanessa Chapoy and Latoya Colley.
Hi.
Hi, how are you?
Good, how are you?
Good.
All right, our next baddie is going to be Vanessa Chapoy. Make sure I'm saying it right, Vanessa. If I'm saying it wrong, correct me.
Boy, Marissa had it right.
Boy. And last but certainly not, oh, no, we don't have Latoya backstage. So we're going to go with the ladies that we have on here. And let's go ahead and get this party started. So, Dr. Salant, one of the questions women tend to get, or comments women tend to get, is the free boob job comment, right? Can you explain the difference between what a boob job is and breast reconstruction?
So breast reconstruction comes after a patient has had an oncologic procedure. So usually with a diagnosis of cancer, or sometimes, very rarely, we are trying to exclude a diagnosis of cancer. And so we are removing breast tissue that otherwise a patient would not have had removed unless they were trying to find out what was wrong, why they had abnormal finding. So reconstruction isn't, really considered the same as having a cosmetic procedure, which is based off of, there is no oncologic need or no cancer need for that. It's simply based off of a cosmetic need, wanting a lift or something like that. That procedure is coupled with cancer or oncologic procedures to reconstruct the breast in a patient who wouldn't have opted for surgery prior, but a lot of times the cancer surgery that we do causes deformity. And so in order for us to try to achieve some form of cosmesis after we create that deformity, we move forward with breast reconstruction.
Oh, you're muted, Jasmine.
Sorry. So I was trying to figure out where the sound was coming from, but we have our last panelist just jumped right in. We have Dr. Frederick Durden. He is our plastic surgeon. He literally just got out of surgery. So thank you so much for making the time tonight. And we'll just go ahead and jump him onto the screen as well. Hello.
Hello.
Hi, Dr. Durden.
Hello. Thanks for having me.
Thank you for being here.
Not a problem.
So, everyone, when it's time to our doctors, do we have crazy feedback?
A little bit.
We might ask everyone to mute their mics until it's time to talk, and that might help. All right. I think we're good. Okay. So, when it's time to discuss breast surgery, what are the options most women will be presented with, and what are the risks associated with those options? And we'll start with you, Dr. Durden.
Particularly for breast reconstruction?
Yes. Well, no, for breast surgery.
For breast surgery, I guess I would defer that to the surgical oncologist in terms of the resection part of the operation.
Okay. So I can answer that question. The two most common things that we offer for breast surgery are either a mastectomy or a lumpectomy, and that is with or without reconstruction. And so a lumpectomy is also considered a partial mastectomy. And what that is taking a smaller amount of tissue with adequate margins so that we can have an equivalent cancer surgery as doing a mastectomy. The difference between the two, of course, is with a mastectomy, you're removing all or most of the breast tissue versus the lumpectomy, you're just taking out the affected area. How you decide on that is based on so many different things. For instance, some patients are only a candidate for one or the other. Usually patients who are candidates for lumpectomy are also candidates for mastectomy, but we don't always recommend more surgery to be better because it can actually be hurtful. Bigger surgeries have bigger complications, and there's no benefit in doing bigger surgeries in some patients because we've shown with multiple patients that have come before in trials that it's equivalent survival. And so really and truly, while a patient could have both options, we'll usually recommend one or the other over the other one. Some patients, unfortunately, are only really candidates for mastectomy depending on what type of disease and the size of the disease. If it's a very small breast and a really large tumor, there's not enough breast tissue to save. You're really doing a mastectomy and you can't reconstruct that breast. And so that's pretty much the two. And of course, there's management of the axilla, but that's really determined by what stage disease you have and whether you have involvement of your lymph nodes.
Now, I know for me, being diagnosed at 26 in 2016, they really didn't explain to me like the fact that the recurrence risk was about the same, whether you got the mastectomy or the lumpectomy. And I think, Marissa, that was one thing that you factored into whether or not you were going to.
Yeah, that was definitely because I was actually offered, well, I had two doctors that told me that I should get a mastectomy. And when I asked, well, how come I couldn't have a lumpectomy? They were just like, well, your tumor size is really big. We don't think that we'll be able to reconstruct the breast the way how you would like it to be. And, I asked, well, what is the percentage of the recurrence rate? And it was literally the same. It was like between 8 and 11%. And I'm just like, well, I'll just do a lumpectomy. Then it doesn't make sense for me to have both of my breasts cut off if the percentage is going to be the same.
Other factors that I did consider when I was having my conversation is I had about 9 centimeters worth of breast tissue affected in one breast, and I was like triple D. And when it was come to talk about reconstruction, it was like there was no way they're going to be able to go that big again. I didn't even want them to be that big again. But I think for some of us, part of that conversation is screening. Obviously, if you keep your natural breast, you have to do screenings more often. And so that kind of brings us to our next topic, which is more along the lines of the reconstruction option. So we've heard about the flap surgeries. We know about implants. We've heard about aesthetic flat closure. Can you tell us, Dr. Durden, what those processes entail and what the risks are associated with those?
Sure. So I think this is a very important topic because we know that we're still deficient in our presentation to women in terms of their reconstructive options at all levels. And so the options have grown. And I think going back to the previous conversation about lumpectomy versus mastectomy and breast conservation versus the mastectomy, it's important to talk about radiation in that conversation too. Because even though you're preserving breast tissue, the factor that there will be radiation changes should go into that conversation too, in terms of making that decision. But when you talk about your options, the options go from aesthetic flat closure, as you mentioned, which is the least complicated or least risk, least associated complications in terms of the reconstruction. And that usually can be combined with a prosthesis of some type, and prostheses are good in terms of having a breast form when you want to in certain clothing. And then we advance from that to implant-based reconstruction. Implant-based reconstruction is normally a 2 to 3 hour surgery. It's normally done in 2 stages, although in the appropriate woman, it can be done in 1 stage, in which we skip the tissue expanded stage and go directly to the implant. The recovery, I would think, would be more along the lines of 4 weeks. It usually does not involve drains or anything of that nature, and it limits the surgery to the actual surgical site. And then we have, from that, we can advance to flap reconstruction. And a flap means that we're taking tissue from some other part of the body and bringing it to the breast to make the breast form. Now, the most common site is the abdominal soft tissue, but you also can use gluteal soft tissues as well to do that. These are more involved surgeries. They usually are more along the line of 6 hours or so for a bilateral case on both sides. It usually is more like a 6 to 8 week recovery, and it has 2 surgical sites, the breast as well as the harvest site where the tissue is coming from. And so that will be the more complicated, more involved, more requiring recovery surgery to have. And then I think that oncoplastic reconstruction for breast conserving surgeries kind of fits in the midline, where we're using the breast tissue to reform it to make more of a natural breast profile. So I think those are pretty much the options, but there are some caveats, and there are many more flaps that we can offer now in terms of different parts of the body that we've learned to use from that, but all of those involve a harvest site and bringing that fat to the breast. If you talk about benefits, the benefits are widespread. Some women really like what an implant breast looks like. They're usually more projected, more rounded, higher up on the chest. Some women really prefer what a natural breast looks like, which usually has some more ptosis to it. And so that kind of makes the decision. And as the other physician was mentioning, some women are candidates for alloplastic or implant-based reconstruction, and they are not for the other. For example, some women have had radiation in the past, have failed implants, have a size requirement that implants can't meet. And then those patients would be more towards the autologous or flap reconstruction side of it. Some women have had other surgeries like abdominoplasties that don't allow them to have flap reconstructions. And so they're more of an implant based. So the choice is varied, and it first starts off with what is safe for the patient in terms of the next stage of their care. And then it goes into what they like or what would make them be more able to get back to the life that they want to live or look the way that they want to look. That's kind of a high-up version of it.
No, but I think that's good.
Mm.
So for Vanessa, tell us a little bit about your breast cancer experience and why did you choose a lumpectomy? Why did you feel like that was the best decision for you? And you're muted, so I'll just say that now.
Okay, so fun story. I've actually had a lumpectomy as well as a double mastectomy. And so I can actually speak to both, which is good. So originally, when I was originally diagnosed with breast cancer, I was diagnosed at a very inconvenient time. My best friend was getting married a few weeks later, and it was a priority for me to be able to make it to the wedding on time. So one thing to consider for lumpectomy was it was a shorter recovery, but also the placement of where the tumor was and the size that it was. I was able to be a candidate for lumpectomy anyway. It wasn't that a double mastectomy would have been better or worse or anything like that. Jasmine, I was kind of like you in the sense that I had very large breasts, and so I was a candidate for lumpectomy. And so all in all, there were a few different reasons why I decided to go with a lumpectomy first. At first, I was having a really hard time because I thought, oh no, I want it for peace of mind. I want to do a double mastectomy. And then my surgeon had explained to me that, well, you could always do a staged approach, but that just means more surgery. And I was like, I'll take it. So really what it came down to was I wasn't ready to have that much downtime. So I had to prepare for work, figure out how exactly I was going to deal with taking off from work. I didn't know how short-term disability leave worked or anything like that. So I thought that going with the lumpectomy first was, I'm not going to say easier. I had the privilege of being able to do both and the privilege of being able to have the option. So the biggest thing for me was the recovery time, but also I knew that if I ever wanted to get a double mastectomy later on, that was an option. Whereas like the other way around, I couldn't have a double mastectomy and then change it to a lumpectomy. Like that's just not a thing. So I think ultimately it was to be able to conserve my breasts for the short term and being able to make it to my best friend's wedding. I know it's, but that is really part of why I decided to do a lumpectomy first.
You're muted, Jasmine.
Is that going to be tonight? Oh my gosh. Okay. But I do think that's a good point. Being able to start with something that's not as radical and seeing if like if you're comfortable with that before you're staging up. I mean, I think that I think Shoni's backstage. Is Shoni's gone. I wish
I also
Shoni
remembered one other thing.
Go ahead.
I just remembered another thing. Another reason why I wanted to do a lumpectomy first is because if I didn't do a lumpectomy first, I wouldn't have been able to preserve my nipples. So, because of like where the tumor was, and going from then a double mastectomy, that was a way that I was able to preserve my nipples in the end. So now I still have my nipples. I've had a double mastectomy now about 2 months ago. And so because I took the staged approach, I was able to do it. Because before I had much larger breasts, if I went straight to a double mastectomy, we wouldn't have been able to save them. So that was another reason. Sorry, I just remembered. I was like, I know there's another reason why I chose lumpectomy. There we go.
Awesome. Thank you for sharing. I think Shoni's backstage. I might bring Shoni on because Shoni, I don't think she wanted a stage approach, but she did end up doing an explant, which sometimes has to happen for women that choose to have implants and they end up rejecting them for whatever reason. So Shoni, you can give me a nod if you'd like to come on screen. Okay, I'm you on. But first, Jamil, I feel like it almost feels like being the rebel going flat nowadays. But you're seeing more and more flatty baddies. When we first was one of the things that we talked about was the lack of imagery of women of color affected by breast cancer. And I mean, to find Black women that have gone flat, to find women of other color that have gone flat, what was the process like for you to decide that this was the right decision?
Yeah, thank you. So, you guys kind of brought up a lot of good points that remind me of my own experience. First thing, being that I had small breasts and a large tumor, so a mastectomy wasn't an option for me. So I knew I had to get, a single mastectomy. That's what they were offering, and then I decided to go ahead and do both. My reasons were just for peace of mind, really, and symmetry was important to me as well. It took me a while to kind of decide, but I decided to go ahead and just go flat. And also because I had to get radiation. That was also the big decision maker as well, because I knew that I needed radiation. That affected me being able to go straight to an implant. So then it was like, okay, do you want expanders? And I decided I want to do expanders. I wanted to give my body time to heal in between whatever reconstruction I decide to do later on. I'm not sure if I want to do it. I'm still deciding. My mind is more on the side of wanting to do it, but it's just a matter of when, because, after going through a year of treatment, I really just want to give my body a rest. So that's where I'm at right now. But I'm happy with my decision. But in the beginning, I was disappointed because I was planning on getting, immediate reconstruction, because I wasn't really knowledgeable about the different options. And when I said radiation, that was totally taken off of the table. So then I had to adjust my plan and get comfortable with, going flat for 6 months at least until I can get my reconstruction. But I'm eligible to get it this summer. I decided I'm going to wait at least a year before I get reconstruction, just for peace of mind and time to heal. And also too, the less complication route was also very important to me. I had a quick heal time for my surgery, and I feel like I made the best option for myself.
Yeah. And do you get a lot of questions from people that ask you?
I do, yeah, because it's not something that you hear or see every day. And then I have my my prosthetics in, and people will think that I've had reconstruction. I'll say, no, these aren't real. These are just pop-ins, But I'm still getting used to everything, the process and having the prosthetics, and what's summer going to be like when I have to wear a bathing suit, things like that. You don't think about maybe I should get the surgery. Like I said, I am more on the side of me wanting to do it, but I just want to wait.
Yeah, I know that was a lot of my decision too. It's just that first year when you're going through treatment and so many surgeries, it's like, okay, so I have to do a whole another one again. And do you want to put your body through all that strain? So I completely understand that.
Exactly too. And another point that Vanessa brought up about work, like I was off work for 10 months. I just went back last month. If I got surgery this summer, I'll be off again for 2 months. So, that's another factor as well. With that, I was just like, what, I just need a break for a little while.
Yeah.
I think these things are so important because we are making decisions. We are forced to make decisions really fast. And we can do by a show of hands how many people felt like all the options were explained to them thoroughly. My doctors were pretty much like, okay, so we're going to do this, and this is how we're going to do it. And if you want to do that, you can't do that here. You got to do that way over there. So we're not really going to talk about that. But we can do this. So we're going to talk about. So that's why this space is so important, to share all the different perspectives and to get all this information, because so many women do not have the chance to have these conversations with their doctors. So I want to bring Shoni on because I know Shoni ended up doing an explant. And one of the things that we wanted to mention is that breast implants by Mentor is sponsoring this webinar. But when we had this conversation with a mentor, we said, even though they do breast implants, we said this is shared decision making, which means we want women to have information to make the best decision that's for them. It's not swaying people to one perspective or the other. So making sure that people knew about the risk associated with breast implants, the risk associated with different surgeries, that aesthetic black closure is an option. All those things we want to bring to the table. One thing that I do know is that breast implants do have a very small chance for causing cancer. And I believe it's lymphoma. And people also can sometimes get breast implant illness, and your body can sometimes reject implants. So one of the reasons I think it's so great to have a good understanding of all the decisions before you make a decision is sometimes your first route isn't going to be your final route. So Shoni, I'm going to let you unplug for a minute, or plug in for a minute rather, and just share your experience.
Hi, can you hear me?
Yes.
Okay, so I'd like to start off first off by saying I did not really get big choices in my decision. It was lumpectomy or mastectomy, and basically the lumpectomy got pushed off the table because it was not just a lump, there was a whole decent size of tissue that I would have looked crazy. Like it would have literally took off half my breast, and I was a double D, and it really wasn't going to work. So the mastectomy it wasn't even a double mastectomy choice. It was just like, okay, just get rid of this breast. And honestly, I just said, okay, because I'm thinking, you know what you're talking about. And unfortunately, because where I am, the options are very slim. And it was either you go with this or you go way over there and try to figure it out. And they might not take my insurance. So I stuck with who I had. And it was honestly, it came down to first getting the mastectomy done. And I said to myself, I think I want the other one, also done. And it was like, okay, so you want to prophylact? I'm like, okay, if you want to call it that, I mean, it's my choice that I don't want to have to deal with both of these eventually, or having lopsided breasts. Long story short, expander on one side, coming down to being able to swap out and thinking that I'm going to have now, straight to implant on the right side. Left side was the cancer side, and that would have went to an implant as well. I got up that a couple hours later, looked down, and I saw still an expander and a flat breast on the other side. So I was like, okay, my surgical oncologist went to town on this side. There was no space left for an implant. Had to wait 6 more months because then I went through radiation. The plastic surgeon and the radiation oncologist did not communicate properly, or communicate with me that once the radiation happened, the expander and expanding the skin was going to be a problem. So they actually had to decrease the expander, and fluid started building up. So it was on a regular basis after radiation. I'm going through them taking fluid out of the expander, because it actually out of the expander actually was floating outside of it also. So it was a whole big issue. Months later, I actually got the implants. 2 weeks after the implant, I literally had a infection up my arm, like in the armpit, and the incision had never really completely closed. And I lifted up my arm and it just started gushing out. And I said, okay, plastic surgeon, something's wrong here. So rushed back in, and they put in a smaller implant. And I was told by a very ignorant fellow that worked with my plastic surgeon, at least one thing I can say is you got a boob. Second thing is, unfortunately, it's smaller than the other one. So basically, I told all of them to get out of my room. And I told my plastic surgeon, if I ever see your fellow in my face again, I might have to hurt him. And he never even in the office, he knew to avoid me like the plague. I could hear his voice, but he knew to stay in the office or wherever he was, not to be anywhere near me. Fast forward, have these implants in, and I'm like, all right, they're going to feel a little bit, they're not going to feel like normal breasts. They're not going to feel as soft as mine did. They're not going to be the same size, but they should not feel like expanders. And they felt like expanders. I was miserable. I could probably walk into a wall and it felt absolutely nothing. They were hard. I had done fat grafting, you name it. Soft. And he's like, my plastic surgeon's like, it's going to soften them up a little bit. It's going to feel, no, none of that. And I said, I'm done. I was like, we're not going to keep putting fat from other places up here and mask the fact that I have these hard, they look like Venus flytraps. I thought I was, part of Little Shop of Horrors with these flytraps on my chest, because they were one so dark from radiation still, and it was actually spread to half of the other side. So I said, I heard about the deep flap. Why wasn't that an option on the table? He said, well, because you are young, you haven't had kids. I said, but that's my option. You didn't put it there for me to say, maybe I don't want kids. You don't know if I want kids. You don't know any of that whole story or backstory. We didn't have that conversation. So that shouldn't have been something that you already decided for me. And this is the conversation I had with him, because I'd already known him for years now. I was like, listen, I've known you already, so I don't understand why, especially since we have this decent rapport, that I can't come to you and tell you this is what I want. And he said, you know what, you're right. So we sat down. It was supposed to be a pre-surgical for more fat grafting. And he was kind of blown out of nowhere to hear that I'm like, let's talk about the deep flap. And that's how we went to it. He explained it to me. And I was honestly supposed to go into surgery maybe within the next couple of weeks, bumped it out of maybe another month, and it was a deep flap. Everyone I knew was like, why do you want to do that? Why do you want to go? Because I want something that's not going to be these heavy rocks on my chest that I will deal with and have back pain. I couldn't even do the things I normally do. I'm an active person. To me, like, not even being able to use my chest or push, nothing. I just was completely out of my element at that point. And granted, the surgery for the deep flap was extensive. But I'd already been through so much that the feeling that I had of not having that back pain from the implants, it may have been the hunch over from my belly, which I still feel the tightness in, which is something they don't really explain fully as well. All of the recovery that comes along with it, the digestive issues that I have because of doing all the manipulation to the stomach area. But I'm actually happy with the decision that I made, because my breasts feel like breasts. They may not be as big as they used to be. They sure really aren't. They're like, I want to say 3 times down from what I was used to, but they fit me more. I used to honestly look at even the implants and I said, they're bigger, but they just don't even look okay. They were just lopsided. And it was like probably one of the biggest horror stories. I'd like, looking at them made me cry. And granted, these are not twins. They don't look exactly the same, but I'm more comfortable with them. I just feel like people don't look at me and say, what are those? Because the way that they were shaped before, I didn't think they looked like breasts. They were just like kind of roundish oval it, and it just didn't look right. No bra fit properly. There was a gap in one side. With now, there is a gap, but you don't see it as much because it's not so pronounced, and they actually have some movement to them. So, long story short, I'm glad I took the initiative to be my own advocate and say, this is what I want, because who knows? Even though I froze my eggs doesn't mean I'm going to be able to have kids. So taking that off the table didn't make any difference, because even if I did have kids, hey, you already have a spot to open up. If you got to open it back up, you go right ahead. Now we get another tummy tuck. Hey, it's fine. But that shouldn't have been an option that was taken away from me. And I told him that, and he was like, he's up here, but honestly apologized, because he said most women don't want to do that and have to go through it again, or if they get pregnant. And I said, but we don't want to do a lot of ifs, because we'll if all our lives. So I'm telling you, this is how I feel. This is what we've gone through, and I'm happy.
Thank you for sharing, Shawnee. We appreciate that. So one of the things April mentioned, we're going to have to, our segments we used to do 45-minute segments, and we thought it was too long. So before we rush into our next segment, one of the things April mentioned is that she was denied the D flat by her first surgeon because she was told she was too large, and then she found Dr. D. So before we head off into our conversation about clinical trials, I want to give everyone a chance to give people some advice. What are some questions that people or women should ask there before selecting a surgeon? What are some questions that women should ask? And we'll start with you, Dr. Cox.
Here we go. I think it's important in terms of when you're trying to figure out where you want to have treatment as a whole, what are the resources available at the institution, what kind of institution it is, what kind of breast cancer do you have, what is your diagnosis? For instance, if you have inflammatory breast cancer, I would recommend going to a center that does have a specialist that is very well acquainted with inflammatory breast cancer, as it's a very different type of breast cancer than other types. The management is a little bit different, and sometimes it's not something that most people see all the time. And so finding out what cancer you have, if it is a subspecialized cancer or something that's a little more rare, making sure you go to a place that has that. The other thing that I think is important is to potentially go to an institution where the surgeons are peer reviewed by the other surgeons. Usually that's done at academic centers. It's done at a lot of other centers as well. But as long as there's some quality metric that's done at that institution where the surgical oncologists kind of make sure they review each other's work and review everything and make sure people are performing the standard of care, I think that's something that's important that a lot of people don't even know about or think about when they're choosing an institution. And then it comes down to comfort. You know, what are you looking for with this? You know, a lot of patients, it comes down to their personal preferences. Sometimes you do meet a surgeon and you're just not comfortable. Maybe you don't feel like you understand what they're saying. And I think that I want to always tell women, or, you know, anybody going through this, you have a small proportion of men too, feel empowered to choose the person that's right for you. Look at, you know, what are the things you want in a surgeon, you know, whether you want them to get a big academic institution or a small place where you can find parking. What are the things that will help not just with the surgery itself, but your level of anxiety? I know sometimes, for instance, I'm at MDM downtown, a lot of people don't want to drive down into the city. But we also have satellite institutions where they can get a different feel of, you know, being in a less chaotic space. So, you know, I think that those are pretty much what I would suggest. A big thing is looking at that quality.
I think that is great advice. Thank you so much, Dr. Cox, for joining us. We so appreciate your time.
You're very welcome.
Jamel, how about you? What advice would you have?
I would say probably just to kind of talk in detail about all of your options. That's kind of the biggest thing I took away from this is that, you know, they go over their favorite option or what they would recommend, but they don't go over all the options. So I think that is probably the number one thing. That way you are educated and can make a decision for yourself.
I absolutely agree. And that's why we're having this conversation.
Dr. Durden, what would you recommend for when people are trying to look for a plastic surgeon and their plastic surgery options?
Am I frozen? Are we back?
You're back.
This is what happens to my parents' house, man. We're working with mentors to create a one-pager that women can use to talk to their doctors about all their options. So I think that's great because, I mean, we don't know what we don't know. We know what we're told, you know? So great advice. Thank you so much for joining us tonight, Jamil.
And then Dr. Durden, what about when patients, after they're getting ready to decide what type of plastic surgery options they want, what are some of the questions or some of the thoughts that you think that they should have those in mind when they're looking?
I think what Dr. Cox and Jamil said were very important points. I think the first thing is that the relationship that I try to have with my patients is more of a family, like treating them like a part of my family. And so I think the first thing is like, do you and the doc speak the same language? Do you guys break on in terms of like you can really get into being comfortable speaking about what's important to you and what you want, and talking about difficult issues? I mean, can you guys get on the same accord? I think that's the first thing. The second thing is very important is to make sure that surgeon has people in their office or covers the full breadth of the reconstructive options. Because like the previous woman was saying, is that sometimes people just present what they know how to do, and like, well, no, flaps are bad because they take too long, or flaps are bad because they're too invasive, or they take too long to recover. When the truth of the matter is that you just don't do flaps. And so asking that question, are there other options for me? And then they should be able to say, yes, there are other options, but when they say but, ask them, do you do that other option for what you're saying the but about in terms of getting that information? And then kind of making sure they have a team set up so that they can communicate and get you taken care of between your medical oncologist, your radiation oncologist, and your surgical oncologist, that they have a tight enough relationship that they can talk, that they do talk, that they have a conversation about you as a patient in terms of how everything is going to come together and fit together for your treatment. And so I think those are kind of the three biggest items to make sure that you speak the same language, because that's very important for expressing what you want. If you can't get that across to the person, they can't understand what you're saying, or you don't understand what they're saying back to you, you can't really get to the bottom line of what you want the reconstruction to be. And this is a very important surgical choice paradigm for a number of reasons. Breast means so much to different people for different reasons.
Mm-hmm.
And it's, no one person has the same idea of what this surgery is going to mean and what the journey is going to be. And so having that ability to communicate will really help make what plastic surgery is supposed to be the part of the operation that brings you back to getting back to your life. That's what it's all about. For some reason it's not right for them. They don't need it. It's not important to them. But that's the function that we have, is that how can we go from a surgery you had to have for a medical problem to getting you back to living as full a life as you can. And to do that, we really got to get on the same page in terms of communicating your idea or your wishes in terms of what you want. So that's kind of where I would leave it.
Yeah, that's great. And that bedside manner is so key, because you can meet some people, like Shawnee was saying, and it's just you can't deal with that at all. Like, I fired a couple of doctors because of it. I'm like, oh yeah, we're just not vibing here. And it's okay. Like, it's okay if you're just not vibing with that person, but definitely find somebody that you can, because you may have a lifelong relationship with them. Yeah. You want to be able to talk to them as, we're talking here, or just with one of your friends.
Absolutely. Thank you so much, Dr. D, and for rushing out of surgery to come here. We appreciate your time tonight.
Before I go, I want to say, this is a very, I thank you guys for what you're doing. This is very important. We know that we don't do a good enough job for educating our patients about their choices. And this forum is really, really, really needed. If there's ever a person that feels like they haven't gotten the answers that they need, feel free to share my contact. I'm happy to try to answer questions, but it's very important, and thank you for doing it.
Thank you.
All right, y'all have a good night.
Thank you so much. We appreciate that. You
All right.
too.
All right.
Bye.
Bye-bye.
Well, ladies.
All right, Shawnee, real quick, make it fast. We're going to move on to clinical trials. What advice would you have?
I just would kind of basically repeat what everyone else said. It's just making, especially what I only saw his name was Fred up on the top. I can't remember the doctor's last name, but he just even having if I had a doctor like him that I felt like that was like family, that is like so essential. You just feel like this person is thinking about me like I'm their sister, their aunt, their something, and it's like, okay, so I know when I walk in that door, I'm part of their family, and they're going to treat me that way, and they're going to make sure that that my best interest is what they're doing. It's not about what they want. It's about, this is like, it could be my sister, it could be my cousin, and I'm making sure that they're going to feel good when they leave. And that's probably one of the biggest things that I have missed through my whole journey, or what do you want to call it. I need to find a doctor like him. At least one.
I will co-sign that. Absolutely. Yeah. Thank you so much, Boo. We'll bring you back on in just a little while. Thank you so much.
All right.
Okay, I'll make it fast.
Let's do it.
Just completely agreeing with what everyone else saying. Just having a good breast surgeon, but honestly, if you expect yourself to have any sort of reconstruction option, it is crucial to have a wonderful relationship with your plastic surgeon. Like, you need to be able to trust this person or be able to vibe with that person so much. I had an anxiety attack during an ultrasound, and I emailed my plastic surgeon, "Can you please come down? I'm freaking out." This man was in the middle of surgery of an operation, and he ran over to make sure I was okay because I was freaking out. So it's like, you have to make sure that you have that kind of relationship with your surgeon, so that you know that they're treating you like as if you're family, like as if like they're your child or family member, you know. But yes, just on top of that, making sure that you take, I know one of the things is also because we think that we don't, or not even that we think it, we definitely don't get all the options right in front of us, but it's also a matter of, okay, we need to get this cancer out of our bodies right now. What do we do? And then afterwards, it's like, oh, wait, we could have done that. But yeah, just if there's some sort of way to like bring all that information together. But yeah, just echoing what everyone said. Agreed.
Thanks, Ruth. Thank you so much for sharing your experience. Y'all know how I feel about time, right? Oh my goodness. Oh, it's a night. It's a night. That's okay. That's okay. We need that information. And there were still some great questions that we didn't get to, like how do you decide between an implant? Most of us don't get those choices of just the implant.
Right.
So yeah, we might have to ask them to do like a Q&A for us, because there's still some stuff that we can dive into.
Yeah.
But
We'll have to have Dr. Durden do that. Maybe him and April could do like a video Q&A and get some of those things answered for us.
absolutely.
But
In the
next,
meantime,
mm-hmm,
yes,
what are we talking about next, Jasmine?
clinical trials and medical research.
Yes.
All right. So we have started our first research project, and it is on race, culture, and clinical trials. And as you guys know, we're a community for women of color, and we are very much so underrepresented in clinical trials. And we want to understand how race and culture impact our decisions. So tonight, we're going to talk about a little bit of the myths and misconceptions. We're going to talk about some of the barriers, and we want you guys to ask all the questions in 30 minutes. Okay. So we are going to bring on our topic experts. We have Tamara Sari, who is going to give our social worker perspective, because I think they are very much so underutilized. If you don't know that you have, I mean, if you have one, you like make sure that you're using them. And then we also have our very own Dr. Alexia. And we have Dr. Tamia Nolan. So let's welcome all of these ladies to the screen. Hello, ladies.
Hey, ladies. How's everybody doing tonight?
Good. Enjoying the conversation.
Yes, so we're going to jump right into it. What's our first question, Jasmine?
Well, wait, we need to bring our baddies on.
Oh, that's right. Sorry, I forgot. My bad.
That's how we're feeling about that time. So we have, and someone said they're all women of color. They are. We did our best, right? Okay, so we also have Shangron Lee, one of our baddie ambassadors here tonight. And we also have, you know what? April, come back. April's supposed to be back here now. April's going to come back here. And Shangron is representing the perspective of someone that is interested in the clinical trials. And April is interested as well. And we already know that Black women, Black community in general, we already have like these really strong stigmas around clinical research. But when we are doing our research, we also unearthed a lot of conversation about shame in the Asian community. So let's do our best to shatter the shame tonight, ask all the questions, and really give women a chance to get access to the most innovative in treatments. Marissa, go ahead, kick us off. First question.
Yes, so our first question for the experts that we have on the panel, explain how your regular cancer clinical trial works and what is a placebo, because I know we get a lot of questions about placebos. So either Dr. Nolan or Dr. Alexia, either one of you, Dr. Nolan, you want to start?
Sure, sure. So, hello, everybody. I am Tamaya Nolan from The Ohio State University. I'm happy to be here with you guys tonight. And so, the type of clinical trials that I actually am conducting are social and behavioral. And so, in those particular interventions that I am interested in, I'm trying to improve quality of life. And so, the interventions that I use are really looking at self-management strategies. How can you really manage things like lymphedema? How can you manage things like anxiety? And then kind of comparing that against usual care. But I do want to make mention that there are other cancer clinical trials that are, drug related. And so again, that's not what I do, but definitely is a large space. And so as we think about clinical trials here today, less than 5% of eligible adults actually participate in clinical trials. And then when we put the concept of race and ethnicity on it, we look at African Americans, for example, less than 3% of those are African American. So we have a huge dearth of information related to, people of color. And that's a huge issue as we think about how are we going to best treat and best kind of combat issues affecting people of color if they're not in those trials and we're not having information about those breakthroughs.
So those are two of very strong points, and one of the reasons, the primary reason that we decided to do our research, because we have access to all these women, and if we're not in clinical trials, then we don't have access to the most innovative in treatments, and then the treatments that are coming out, they might not be effective for us, which we're starting to see in so many spaces, like the oncotype test that's been the thing, and all of a sudden it's like, well, maybe not so much for Black women, it's effective. So yes, and I think that's the other thing too, is making sure that people understand that clinical trials in nature are not a last ditch effort. A lot of people think that's the only time that you look into clinical trials or you talk about clinical trials is if you're stage 4, and that's not the case. In a general cancer clinical trial, it's not that there's a treatment and no treatment. It's the standard treatment and the new treatment. People are afraid about going into clinical trials and not receiving treatment, and they're not going to do that to you. They're not going to send you out there and to not treat you at all. So I think that's one of the biggest concerns people have about clinical trials, and it's a huge misconception when we talk about the placebo. Standard care versus new care is the idea. Now, Tamara, am I saying it right? Tamara. Tamara, it is Tamara. I'm so sorry. Tamara is actually my social worker at UF Health. She's helped me in more ways than I would have ever thought she would have been able to help me. And not just me, she's helped my family, so my mom, my grandmother. Not everyone has access to a social worker, but some people have access to a social worker and they don't know it. Some of the reasons women are saying that they cannot participate in clinical trials or things like transportation or childcare. So what is the role of a social worker in a hospital, and how can they help women navigate those challenges?
So before I answer your question, I just want to say thank you so much for this opportunity. And I want to say thank you to the previous presenters and the ladies for sharing your stories. So as you stated, I'm at UF Health Jacksonville, and UF Health Jacksonville is in a very low income, low socioeconomic area. It's a very underserved area. It is a research hospital, and transportation is one of the barriers that a lot of our patients face. And so as a social worker or case manager, what we typically do is our role is we're responsible for addressing any psychosocial barriers that might come up that can potentially, again, be a barrier to that patient having a successful treatment, right? So there is transportation, there's the financial stressors that come up. There's a lot of young ladies who are diagnosed with breast cancer. They are caregivers, they're mothers, they may be caregivers to their own parents. And so things like childcare might come up. How am I going to get this chemotherapy treatment or participate in this clinical trial if I don't have anyone to watch my children for me because they are not of childcare age, or now due to COVID, a lot of parents don't want their children participating or attending childcare. So my role at UF Health as a social worker case manager is to identify what those psychosocial barriers are. And at that point, once we identify what those barriers are, I address those barriers. And of course, that's through facilitation of referrals, educating patients on what resources are available to them, assisting those patients with completing those applications. I actually do a lot of research. I have to research a lot of resources to find out what's available to patients. And also a part of my role is to provide some short-term counseling. In the previous segment, I heard a lot of, I didn't have a choice, or I was rushed into making this decision. And I am very strong on educating patients on, hey, the patient rights is a thing. You have a right to you have a right to talk to your doctor about what you want your treatment plan to look like. You have a right to ask those questions. If your appointment is for 15 minutes or 30 minutes, you have a right to be in that appointment for the allotted time so that you can get those questions answered. So it's not only addressing the psychosocial barriers as far as the practical needs, but a lot of my responsibility is also addressing those emotional needs that come up and empowering my patients as well, so that they do know that they have a voice.
Now, for
that was actually,
oh, go ahead, Jasmine.
That was actually a scenario that we went through together. It was, I don't feel like she's giving me all the information. And I think we were just having like a casual conversation, but you were able to act as a mediator between the doctor and I still ended up switching doctors, but, you were like almost like a patient advocate.
Yeah.
One that's like, hey, we need to address this. And so in our community with women of color, we talked about the burden of being strong on an episode and not wanting to ask for help.
Yeah.
Ask for help. Mm-hmm. Like, you guys may be missing out on so many resources. You may be going through so many unnecessary hurdles just because you haven't asked, is there someone that can help me navigate this?
Mm-hmm. Mm-hmm.
See, and that was going to lead into my question too, is like how, when you do have patients who are afraid to ask or they have that shame, mm-hmm. how do you approach that, or how can they be more open to saying, is there a social worker that I could talk to, or is there somebody that I could talk to that can give me those resources? Because a lot of us, like Jasmine said, we just don't speak up.
Yeah. So as the only social worker, case manager for 6 oncology clinics at UF Health, it's very difficult for me to make myself present during the initial consultation or the initial appointment. So what I decided to do was I created a flyer that has my information on it. It explains my role, all of the services that I provide, along with my contact number. I also encourage managers of those clinics, the medical assistants of those clinics, to also let the patients know that I'm available. Now, in our clinic, we actually have what's called it's called a psychosocial distress assessment. And it's just one page. It's a document that patients will fill out. On one side, there's a thermometer so that the patient can circle what their distress level is like. And on the other side of that document, the patient just they can check off what their identified stressors are. Those forms are actually sent over to me because that triggers a high distress. And so when I get those documents, that form, that assessment, I get in contact with that patient. I introduce myself either via phone call or I'll pull up their schedule to see when is their first appointment for radiation or chemotherapy, or when is their next doctor's visit. And then I go over and I visit with the patient. I meet with them in person. I explain my role. I further assess their needs. And then we talk about resources that are available to them. And I try to make sure that I do an extremely good job. Again, bedside manners. That's extremely important to me. And like I think Dr. Fred said, I treat every single patient like they are a family member. I don't care what the color of your skin is. I don't care if you're insured or uninsured. My primary goal is that you know that I am sincerely here because I care and I want to help see you through this. And if there's something that I can do in my role to address those barriers and those stressors, I'm definitely going to do everything within my power. And also, follow up is very important to me as well. So I'm not just shoving resources and saying, here, give these agencies a call. I follow up as well. And if I have to hold someone's hand, I'll do that. I'll do whatever it takes in order to minimize some of the stress that patient is already dealing with, once they learn about their diagnosis.
Yeah, and I would say like just working with you personally, like I know when I had to reach out, I'm like, I don't know if this counts. My grandmother, she has NBC, and we're having to do with all these other things. We need help, and like I feel like I didn't have to worry. Like I'm like my mom is in good hands, and like I know that my mom felt like a burden was off of her. Because she was in a place, my mom lost a lot of weight in a short time span, stressed out. Because she didn't know what to do or where to turn. And I was like, the only person I can think of is and you helped. And I'm sure it was like kind of like out of the realm of it. Like you say, you do a lot of research, but you were so helpful and we are so appreciative of that. And I think I just can't imagine how many women are navigating barriers on their own where there's maybe someone like you that could help.
Absolutely. And if I can just add, counseling is it's a passion of mine. And unfortunately in my role, I'm not able to do that long term for patients when they're in treatment. One of the things that I see with women of color is that they are not very open to seeking counseling. And that is something that I highly encourage. There are a lot of therapists of color that are in Jacksonville that I have connections with. There are so many different types of therapeutic modalities that are available that can honestly help when you're trying to make these decisions about, what type of surgery am I going to have? Do I want to have a lumpectomy? Do I want to have a mastectomy? Do I want to have reconstructive surgery? We know a lot of things come up about body image that's very difficult for women to deal with, especially when we're living in a world where a lot of women are wanting to enhance things and to have to make that decision about should I, keep my breast or should I, have this particular surgery. It is a difficult decision, and counseling can help with that tremendously. And so as a woman of color, I highly encourage that we as women of color be more open to seeking out therapy and counseling to address some of those things. Counseling actually improves quality of life as well. And there actually has been research done that shows that when women engage themselves in individual counseling, it actually increases their quality of life and their likelihood of survivorship. So I just wanted to add that.
Thank you. We are big champions of mental health. I've always said that I feel like mental health should be just as important as chemo and radiation as every part. Our bodies, our lives go through so much in a really short time frame, and even afterwards, especially afterwards. Mm-hmm. So if you hear that, ladies, take it to heart. She's talking to you. So someone asked about resources. Are there resources available to patients that are no longer in active treatment? So, well, I'm not in active treatment. I just call you when I need you.
Yeah, sure, absolutely. I mean, whether you're a year out, 6 months out, 2 years out. Now, I do make a joke, and I do tell my patients that once they complete treatment and they, they are, the cancer is no longer there. I usually do tell them like, I never want to see you again, because that's just a good thing. Like I don't want to see you come back to the oncology clinic again. But at the same time, I encourage them that if you need me, I definitely want you to reach out. So to answer that young lady's question, I think is I don't know, Miss Brown. I don't want to mispronounce her name. Some foundations are available for women who are no longer in active treatment. Usually, if you're 6 months out from treatment, there are a couple of foundations. One that I can think of, like off the top of my head, is Cancer Care. Cancer Care is wonderful. They provide financial assistance for things like transportation, child care, lymphedema sleeves, mastectomy bras. So if you just Google Cancer Care, I do know that is one cancer foundation that does provide financial assistance to women who are no longer in active treatment. But that is a good question, because I have come across a lot of foundations that require that the patient is in active treatment. Even my active treatment could also mean a recent surgical procedure, such as a lobotomy, a mastectomy, even reconstructive surgery. And they usually, again, will define active treatment as, presently in treatment or within 6 months. But I think Cancer Care even maybe is like, they don't even care. They're more like open to helping a lot more patients. So yeah, I see the across the screen. That's awesome. I like that. Thank you for asking that question. And Jasmine, I know, Jasmine, you have my email address. So if you want to share it with everybody, I'm totally fine with that. That's not a problem at all. Whether you're treated at UF Health or not, it doesn't matter to me.
And you've also written for us before. I feel like we have to have you back for another Q&A, because you guys, you're missing out. If you don't ask the question, you're missing out. Okay?
I would love to come back.
Now to our baddies. April's like copping in. She's like a me tonight. She must be on my Wi-Fi. So when it comes to clinical trials, Dr. Alexia, you have participated in a clinical trial. Shangron, you have not, but you're interested. April, I'm going to hop you back on here. You have not, but you're interested. Shangron, we'll talk with you. How important is your family's opinion in this conversation, and whether or not you would consider a clinical trial?
It would be important to me. My husband is actually a physician, so I depend on him a lot. And I really appreciated his support throughout my cancer journey. So if I were to decide to do a clinical trial, I would definitely consult with him and see what his thoughts are. But of course, I would do my research first before I would discuss it with him. And he's pretty open, so it's so that's good for us.
April, what about you? How important is your family's opinion in the conversation of clinical trials, with the understanding that clinical trials aren't a last-ditch effort? They are offered in all stages for all different aspects of life after a breast cancer diagnosis. Is she frozen, or am I frozen?
I think she's frozen.
Okay. That's okay, April. We might have to come back to you, boo. Dr. Alexia, you have participated in a clinical trial. How important was your family's opinion when you made that decision?
When it comes to all things medicine, because I'm in the field, I tend to be a little more adventurous and a little less skeptical than my family. So they're always like, you ain't gonna. And I'm like, no, yes, I am. No, I'm going to do this. So my initial clinical trial was an observational clinical trial. It did require a few and blood tests, but it wasn't like a investigational therapy. So it was looking at my heart function and trying to figure out when on ACT do women start to experience heart damage. So instead of waiting for me to become symptomatic, I got ultrasounds of the heart and blood tests, and I could get screened as soon as I became symptomatic. And I actually did become symptomatic from the chemo, and I was able to get screened through that clinical trial. And I'll continue to be observed for that. And then post treatment, I'm also in the clinical trial where they look to see if you have circulating cancer cells, and it's observational, and unless they find circulating cancer cells, which would mean, at some point you're going to become metastatic, but rather than waiting until you have mets on a PET scan or X-ray, they will then put you on two different pathways, either traditional therapy or giving you one of the therapies that they would give you for metastatic cancer. So, I'll see. I hope that they don't find any circulating cells, but it puts me in a better position, because otherwise I'm essentially just getting, screened via PET CT, which there's not really a standard protocol. It varies from place to place. And so I'm 3 years out, but I've only had, one PET CT since I completed chemo. So, trials, we mentioned placebo cancer trials. If they're therapeutic trials, placebo is not involved. It's the standard of care versus the investigation, as Jasmine already said. And I think it's important for families to understand that, because families' opinions do weigh heavily on the treatment decisions that people make, especially because these are going to be the people who are supporting you if you experience side effects or toxicities of a medication, and you're looking and leaning to these people for support. You don't necessarily want them to be like, see, I told you so. But in our community, especially, our families' opinions on us, and how we like to name drop, right? We want to name Henrietta, we want to drop the Tuskegee trials. And so it's important to help your family and your supporting system to understand that those things should not and would not happen these days, and why they wouldn't happen. So yeah, I'm more likely to just jump out the window, and my family just has to watch and deal with it, but they'll hold me up.
So Dr. Nolan, I guess that kind of segues us into saying, how would you best recommend someone discuss clinical trials with their family?
Yeah, I think the best thing to do is really to invite your family with you to have the conversation with the clinical trial coordinators, because it's one thing for you to go back and tell folks your version, but you hear it from the horse's mouth. And so, as much as we can, we try to involve the participants' families in these discussions, and so that everybody is knowledgeable, and that you can have a informed discussion at home and come together and make that decision of whether or not you want to participate in a trial. And I really appreciate Dr. Alexia's mention of, Tuskegee, Henrietta Lacks, like guinea pigs. We hear that all the time, right? And so it's important to kind of negate those myths. Nobody is a guinea pig these days. They don't let us do that. We have institutional review boards. They don't let just anything kind of go through there and let Jekyll and Hyde do all kinds of stuff on you. No, that's not the way that science works these days. We really have to kind of get past that and realize that, again, as I said earlier, if we're not a part of these trials, we're going to be left behind. We're absolutely going to be left behind. So the potential participant, those family members, gotta be there, gotta have that conversation. And then we always give these long drawn out consent forms. Okay, great, that's fine, but ask questions. anything you want to know. There's no stupid question. There is no, question that you shouldn't be able to ask. They can give you the answers, and then you make an informed decision. That's the best that I can say is, bring folks along with you.
I love that advice. And so one of the things that I've talked about is I don't think it's not like it's not a get over it kind of thing. I think it's a bring people along with you. And I don't think the medical community has done a good job of bringing communities of color along with them as the changes have been made. And now here we are, and people they don't understand. So one of the things that have come up, at least in our research, is people they just want to understand. And things aren't really being presented in a way that's easily digestible. One of the things that come to mind is when they talked about what the placebo was for the COVID vaccine clinical trials. When they said that it was saline, there was a lot of like, well, duh, conversations that this is why it's so important for us to be culturally sensitive when we talk about medical research, because when you say duh, it's saline with no context of how clinical trials work. For Black people, that's going to sound very Tuskegee-ish. You know what I mean? I know that it's not, because I'm an advocate. I've done research trainings, but to the average Black person that does not have that kind of exposure, to the average person in general, that might sound a little Tuskegee-ish. So I think for us, it becomes, how can we educate the baddies so that you guys feel comfortable asking questions? And then how can we work with the medical community so that we can make things more digestible? And that's what we're hoping to get to at the end of this research project, understanding how can we as a community work together to bring the community along, because it is so important.
And
So
if I may with that though, that's a great point. And so one of the things that we're doing at The Ohio State University is we have a community scientist academy where we're doing just that. We are bringing folks from the community in, educating them on what is a clinical trial, teaching them about the different phases of clinical trials, and then also, giving them the opportunity to learn about things like Research Match, where you can, sign up yourself and put in your, demographics, information about you, and they will contact you about clinical trials. And then you go out into the community and you talk about that. And so you're absolutely right. We've got to work with, our communities in order to really dispel these myths and really get folks on board as far as participating in trials. I think that is, one of the best things that we can do is we have to work together. The other thing that we're doing at The Ohio State University is actually tomorrow. We have a academic, community, government, biotech company webinar, everybody together on one webinar where we're talking about just that. How can we promote clinical trial participation in communities of color? And so we'll be there on tomorrow at noon. If you want more information about that, you can go to joshuajosephmd.com. That's my colleague, Dr. Joshua Joseph, and he has a wonderful webinar information right there. You can do a little click link, joshuajosephmd.com, because we've got to come up with some solutions, working together with you guys for the rest of us as well. Everybody, if we're working together, we can move mountains. I'm telling you.
Yes,
absolutely. So one of the questions you said, Joshua Joseph MD, because y'all know I'm trying to drop these links in there. One of the questions that we have though is for Sharon, in the sense of how do we overcome shame so that we are willing to have these conversations? And I don't think for Black women, I don't think that it's a sense of shame as much as it becomes like a privacy matter. But one of the things that we're coming across in the Asian community is that there is a sense of shame. Is that something that you've experienced? And if so, how have you worked to overcome that?
Yeah, I do have that experience with my parents, especially with mental health. But I think for shame, it's more of the first generation that live here in the US. As for myself, I'm second generation, where I think we tend to be more open about it. But part of the shame is also privacy as well. So for me, how I overcome it is I just talk about it. And, especially with my parents, it's uncomfortable. to talk about it. So it's usually just kept quiet, and you just hope it just goes away. So I just confront it. I just deal with it, and I just talk about it. And I've been thinking about how I could be effective as an advocate in the community, but where I live, it's not as accessible as I would like to be as a person of color. So I guess, yeah, I just have to keep talking for myself and just find those opportunities out there where I can be part of that, where I can help out with the Asian community, not to feel shame. Part of it is that, like my IG page, where I talk about my mental health, for example, so that I can find other women to connect with and build community that way. So I don't know if that answers your question, but like for my parents being first generation, it's a lot of work. It still is. Even when I had my breast cancer diagnosis, my mom really rarely talked about it. So it seemed like she didn't care, but she did. But she just didn't know how to talk about it and be, I guess, sensitive, or be able to express her feelings. And I think it's just because part of that is the culture where you just don't talk about it. So I've learned to be open and talk about it. My sister, who's 5 years younger than me, she doesn't really talk about it. So I'm always the one that has to make the initiative. And sometimes when I do that, I feel like I'm being the black sheep of the family. So, but you just have to keep pressing forward. If nothing changes if nothing changes. So if you want to see that change, you have to be that change.
Mm-hmm. Yeah, absolutely.
Absolutely. And I don't want you to undervalue the importance of simply sharing your experience. That's one of the reasons that we created For the Rest of Us, the power of sharing stories and understanding that we're not alone, and understanding that our stories will become the guides for somebody else. You know what I mean? It's the things that we probably feel most embarrassed about that someone else is dealing with quietly, and they see that somebody else is willing to talk about, that make all the difference. So we are, in a sense, like shattering the shame every time we are willing to talk about it, every time we make a post, every time we become part of a panel. And that in itself is incredible for the communities that we represent.
Can I add something else to that? So like during my breast cancer journey, I had a hard time finding other Asian women that I could talk to or feel comfortable that looked like me. And so I was diagnosed in 2017, and I started my IG profile in 2019. And that's when I was able to find more women like me. But then I also realized, if I want to see more Asian women in this capacity to be advocating, I am trying to look for that person. I'm like, wait, I gotta be that person. So, for me, I'm really stepping out of my comfort zone. I'm naturally an introvert, so it's been a game changer for me, and I'm very thankful for it. So.
Well, thank you guys. Thank you, ladies, so much for joining us. Is there any final thoughts before you guys leave? Some thinking things that you want people to keep in mind when they think about clinical trials. Besides, ask questions, guys. Ask questions and ask for help. Anything else?
One thing I wanted to share is that you don't have to wait to be invited to a clinical trial. You can ask your doctor if they're involved in clinical trials, and if they're not, because every doctor isn't, then you can seek out clinical trials on your own. So you can go to clinicaltrials.gov, you could go to cancer.gov. There's also a phone number is 800-422-6237. you know, getting involved or seeking out clinical trials is a good reason to pursue a second opinion with another doctor. And then, as Jazz and everyone has said, when you either get invited on or if you find a clinical trial, like ask questions, get as much information as you can about your diagnosis, because you can't just be in a clinical trial because you want to be. There's specific criteria for clinical trials. So they'll want to know things about your cancer tissue type, your stage, they want your pathology results and lab results and what treatments you have. So if you're seeking a clinical trial, you want to gather all of this information or make sure it's readily accessible, which with the recent CARES Act change, right, we can see everything in our patient profiles now. We can see the doctor's notes, we can see all the labs, the imaging, the pathology, all the things. We have access to that electronically. So gather information to present to the folks who are doing the clinical trials. And just be open, and as was said, take somebody with you. Just because you go seek the information, meet the clinical trial team, you don't have to participate if you don't want to or you don't feel comfortable. You can end your participation in a clinical trial at any time for any reason, but just know that your participation in a clinical trial doesn't just help you potentially, it also helps your community. It helps your family, your friends. It helps the other women and men who look like you and who may share your same experience in the future. And with that, I'm complete.
I think the mic right there. You said it all, Dr. Alexia.
Well, thank you so much, ladies, for participating.
That there's another website too that you ladies might be familiar with, the National Comprehensive, I think it's National Comprehensive Cancer Network, which is the NCCN. I don't know a lot about clinical trials, but I think that website also provides information about clinical trials. And one of the things that we do at our hospital is we encourage what's called like a teach back, because a lot of our patients are not, their educational level, they're challenged with that, right? So as we're talking to them and we're sharing information with them, we're asking them to repeat what we've shared. That way we try to make sure that they understand the information that's been provided to them. So I just wanted to share that information. And I also just wanted to encourage, I hope I don't mispronounce your name. Is it Shangrong?
Yes, that's correct.
You're definitely not the black sheep of your family. You're the one that's been the impactful one in your family. You're being impactful, and you never know what impact you'll make as long as you keep talking. So I encourage you to keep sharing it and keep talking about, everything that you've dealt with so far, because you're making an impact for sure.
Okay, thank you. I appreciate it.
All right, ladies. Thank you all so much for an awesome segment. We so appreciate your time, and we appreciate the conversation. And we hope that you ladies have learned something, our baddies. And with that, we're going to take you ladies off the screen. Thank you, guys. You have a great night.
Thank you. Thank you so much.
Guys, we're running. We're so sorry. We might just have to go back to 45-minute segments. That's how we're running tonight. But this is our last, but certainly not least topic of the evening. This has probably had like the most energy around it last year. And that is we put in parentheses, fertility conversation. So we are very happy to have back Dr. Tiffany Jones. So awesome. And then we also have a new panelist. We realized that we talked a lot about fertility preservation and we didn't really provide any resources. We have someone tonight. Her name is KK McCaslin. You're going to have to correct me, I'm sure. But for Live Strong Fertility, and they might be a resource for some of you. I've talked a lot about how Live Strong and a couple of other nonprofits helped me with my fertility preservation process. And then we have some baddies on board. We have Melissa Davis representing our MVC baddies. We have Greta Abraham, and we have our baddie ambassador, Christina Simmons. So I'm going to bring them all on stage at one time.
Definitely an important conversation that everyone wants to discuss. So I am happy that we have a great panelist here tonight, and hopefully everybody can give their perspective, especially with the adoption, because I know that that is new. We did not talk about that last time. And I know, especially in communities of color, adoption isn't really talked about that much, but it is an option. So it's something that we should definitely talk about and bring on the table here. So welcome, ladies.
Hi.
Hi.
How's everybody doing?
Hello, Owen.
Hello.
Hey, we're going to jump right on in. So I think Dr. Jones, when is the best time to have the fertility talk after a breast cancer diagnosis?
So, when you get a diagnosis, it's a whirlwind, as everyone on this call knows. But the sooner the conversation can start about fertility preservation, the better, because usually there's a very limited window between the initiation of treatment and all the evaluation that's going to go on that would allow timing for fertility preservation. So although getting a diagnosis is such a hit, you have to kind of keep going and just get all that information because time is of the essence most of the time.
One of the things that women have talked about a lot is feeling really rushed. And I think Vanessa spoke to this a little bit earlier when you're in those moments and you're like, come on, we gotta go, make a decision, we gotta do it right now. Guys, for some programs, you have to do the fertility preservation before you start active treatment, like before you do chemo and things of those natures. Something that I've been talking to people a lot, especially in the shared decision-making space, this idea of understanding what the patient's view of quality of life is very important. And it's not always taken into consideration. I think it's important that after you're diagnosed and it feels like everyone's rushing you to take a beat, and make sure that you are keeping in mind the life that you want when it's all said and done, right? After you've done all the tests and all of those things. And making sure that your doctors are on point with that, like they're in agreement with that. So yes, as soon as possible, definitely. And for me, it actually was not my oncologist that brought that up. After I was diagnosed, because my OBGYN was the person that started the conversation, that's who I went back to. My oncologist said, like, we'll worry about cancer now and babies later. And I was like, I don't know about that. There might not always be a later for some people. So let's make sure that you bring up the conversation. If it's important to you, bring it up as soon as we start talking about treatment planning. So Dr. Jones, what are the options for fertility preservation?
So for fertility preservation, if you're single, you can freeze eggs, and that usually is about a 2 to 3 week process. You can freeze embryos if you're single, because you can use donor sperm if you desire. If you have a partner, you can freeze embryos with your partner. Ovarian tissue cryopreservation is a newer form of fertility preservation. It's not offered at many clinics, but it should be discussed, especially if there's a limited time, because the eggs live in the cortex of the ovary. That cortex can be harvested in a very minor procedure, laparoscopically. That tissue can be frozen. It can also be reimplanted at a later time to give you back natural hormones, and also to potentially lead to natural childbirth or to do harvesting of eggs to create embryos in the future, because those eggs in that cortex have never seen chemotherapy. They were actually frozen before you started treatment. So those are the mainstays of fertility preservation for women: eggs, embryos, and tissue.
And that tissue.
I have never heard of that last one.
There's also also could use donor eggs, but if you're talking about just your own gametes, that's what we would be discussing. Yeah, it's very, it just got kind of unlabeled as experimental, but most of us, haven't trained. Like I myself would have to get special training to do it, and the lab, of course, because what's really important when you're doing these things is that you go to a place that is going to be able to give you back what you need. If you freeze your eggs, thaw them, and then they don't give you embryos, like you can't go back. You've already had chemo. Right. There's a potential. And so the same thing with freezing ovarian tissue. You would want to go to places that actually, did the research, had people who were thoroughly trained, and the lab is good at it. And eventually most of us will get there because it's not terribly complicated. But right now I wouldn't offer it to my patients because we're not doing it. But I would definitely tell them about that option and who to seek out. It might require some travel. Insurances likely aren't paying for it. So that's a really big thing. But, just to let people know that those options are available at some places.
That's amazing.
That's cool.
Were you going to do a question?
No, I was just going to say that's cool that that's a new option that's on the table because, when I was diagnosed 5 years ago, that was, I'm sure even women that were diagnosed just a couple of years ago, even after me, that was something that isn't on the table. So that's great.
So I want to bring on, am I frozen? Tell me if I'm frozen.
Nope. You're not frozen.
Okay.
Because
you guys are frozen for a minute. Okay. So I want to bring on KK because this is where, when we're talking about fertility preservation, this is typically where the cost will make or break many women. For me, I was one of those women who was legit sitting in the office when they told me how much it was going to cost, and I looked at my ex-husband and I said, we have to leave because we can't do this. I was blessed to be at a very awesome fertility clinic, and they were the ones that started this conversation of, before you say you can't do it, let's look into some options. So tell us about Livestrong Fertility and how Livestrong is working to help people affected by cancer.
Awesome. I just want to thank Jasmine and Marissa for inviting me today and for having this conversation, because as you all pointed out, it doesn't happen enough. So I'm just really glad we're addressing the topic. What the Livestrong Fertility Discount Program does is it offers a minimum 25% discount on fertility preservation for individuals impacted by cancer. We are partnered with over 700 clinics across the US to offer these services to both pre and post-treatment cancer survivors. And at Livestrong, we define survivor as the point of diagnosis and beyond. So at our clinics, we offer egg freezing, embryo freezing, sperm banking for males, and we also offer full cycle fresh or frozen IVF. And we extend those services to the spouses of male survivors as well. So for example, if a male banked his sperm before treatment and then his wife wanted to go through IVF, we would be able to support that, which is really special for our program. The great thing is, we have very inclusive eligibility criteria for our program. We have criteria for single individuals, for couples, with financial different thresholds. So we try to be very inclusive. We accept people who are physically present in the US. You don't necessarily even have to be a US citizen. And we ask for very basic information for our application. So we ask for a verification of income. We ask for a referral from your oncologist, and it's just a form we wrote out. We don't have to get a big fancy letter or anything like that. And we also, for our female clients, ask for a referral from the reproductive endocrinologist, which is the physician you would work with at the fertility clinic. And once we receive those 3 pieces of information, it only takes us 24 to 48 hours to get you approved. Because like you all said at the beginning of this, time is of the essence if you want to do this pre-treatment. And we really want to be respectful of that because cancer survivors can't wait.
I love that. I love that thought. So question, do you have options for post-treatment?
Yes. Absolutely. So our post-treatment agreement says that the clinic will honor the services that are offered to pre-treatment individuals. So if you went through treatment and you still want to do egg or embryo freezing, like Dr. Jones mentioned, that is an option with that agreement. And then again, we also support people who want to go through full cycle fresh or frozen IVF in our post-treatment. So let's say you froze your eggs before and then you're finally ready to go through IVF. We can help with that as well.
Wow, I did not know that. That is so awesome. I get emotional because like you guys, like I'm looking at the chat here and someone's saying how they declined because of the cost. I seriously, I had talked to the fertility specialist and he said, you know, I don't think that you should be turned away because you can't afford it. Like no one asks for cancer. This is what the reality is. And apparently that memo did not get to the front desk. So we came back thinking that we were going to start the process and the lady said it's $10,000 right now. And that's what I said. I looked at my husband and I said, we can't do this. And I wanted to cry. I felt devastated. And I literally I was sitting in the waiting room and they went to the back a few times. I have a blog about this and I'll probably share it because this again goes back to asking questions because what they did was in addition to helping us get into the Live Strong fertility program, I think we also did a Walgreens Foundation program that helped cover the cost. And they did a payment plan, which they did not normally do. And like at first she was like, well, how about we do $800 a month? And I was like, how about we not? Like that's another
Range
mortgage.
Rover.
Like, where am I gonna get that from? I'm still in radiation. I'm not working. And we literally, she said she came back a few times when she left the first time. And I tell you, I prayed the hardest prayer I've ever prayed in my life. I prayed. And she came back the third time and she said, how much can you do? And I said, 230. She said, deal. And they set up a payment plan and we paid it off over the course of a couple of years. But that's again, like when you get them to a space to where you're willing to ask questions, you have to like be willing to do that, be willing to advocate for yourself. So someone asked about the best time to apply because they went and the application was closed. Do you guys have time frames?
So we accept a certain number of applications a day. So like I said, we have 700 clinics across the US competing for those spots. And competing is not really the right word. You know, these cancer survivors, it's not an everyday thing in the clinic necessarily. But these clinics recognize that that is a need. So they have these agreements for when those people do come up because we're not directly partnered with all like giant cancer clinics. We also work with like little tiny clinics that are standalone. So we want to have options for everyone, you know, who can't get into those fancy health systems or anything like that. And I did want to add that our program also offers free stimulation medication to women that are approved through our program. I see some nodding on the screen, which is a big cost savings. We save women an average of $4,300 just on that medication. Which, as you mentioned, the Walgreens program is also a great program to get your medication from. But, you know, we try to do everything we can to defray costs for individuals impacted by cancer.
Yeah, I mean, my cost went from 10,000 to 5 after the help, and we did pay that over like a course of a couple of years. So we want to like again ask the questions, do research, reach out. Well, again, this was because I went back to my like fertility was important to me. I went back to my OBGYN and she sent me to a fertility clinic that cares doing the stuff, right? Okay, so Shoni, I see you down there. I want you to share what your experience was like navigating fertility as a single woman and having been a little older in the young breast cancer community. What was that like? What is that like for you?
First, I want to say that preserving my eggs was my idea. They basically were like, it's time for chemo. And I said, not for me. We're going to freeze some of these little Shawnees before we go any further. And to be honest, I didn't really know what the cost was, but I knew to myself that this was going to happen before you're going to start chemotherapy with me. There wasn't the option of even the embryo, even though I wasn't dating anyone. I was completely single, but that was still not something that was said to me that, you know what, freezing an embryo may be a better bet for you because you are not younger than 35 years old. One, because then actually know you have an embryo, not eggs that you may not be able to use. And to be honest, if that extra cost was added in and I understood that was a better chance for me, it would have been something that I would have said, I'll fork it up and figure it out. I actually went to the fertility clinic that deals with the healthcare system that I'm in. They only have one, and it's literally in my area. That's literally the healthcare system that runs a lot of stuff. So they honestly didn't take my insurance. I went in there because I said to the nurse navigator that deals with breast cancer, I need somebody. I need to figure out what's going to go on. Either you're going to help me or I'm going to figure it out myself. And she was actually helpful. It doesn't work there anymore, but that's one of those things. And I went in, and the doctor that was basically took my case was the head of the whole fertility, like he was the chief of the fertility clinic. So he said he was going to almost take my case sort of pro bono, but not completely, meaning that the fees that I paid were not going to be a full IV, like a full egg freezing pricing. It was more like they're going to scale it down. I did use Livestrong because the nurse that was working with him was so lit. She's like, listen, this is what we're going to do for you. She was the most helpful, to be honest, because he didn't really know everything, the ins and outs. He was just trying to help me on the strength of me being a breast cancer patient at the time. Unfortunately, I ovulated too fast during my first cycle, and he decided he wanted to bring in my twin sister because I have a twin sister, and I didn't understand why. He says, as she got into the room, so what do you think about freezing your eggs for your sister? And I looked at him like, are you crazy? Are you like, I didn't even, and I couldn't even muster up enough to ask him if he was crazy. The tears just rolled down my face that it's like you took away my option and you just gave it away. Like you didn't even say to yourself, go ahead and you can try one more time. Or like, and I said, I'm not doing chemo because if this is saying that I'm not going to have any kids and I can't try now, I was just completely out of my mind at the time, because when I walked in the door, the first thing I was even said to my oncologist is like, I want kids. I may be single right now, but who knows? There's so many different options out there, and I shouldn't be denied just because I am single. So I eventually did freeze not very many eggs because I was 36, and they were like, you're lucky you got as many as you did. And I kind of felt like a little poo-pooed on as they said that to me too, because they didn't explain to me as well, that because of my age, they're going to get a smaller amount of eggs. Even when they were showing the follicles, and they're showing me as they're doing all the different sonograms that they did on a regular basis, because I lived in that office about 2 months. I actually was like, then I started to understand because I started asking questions, but I saw so many different doctors that it was just like, I didn't know who to ask. So eventually I did freeze eggs, went through my treatment, and I'm on the other side now. So I said to my oncologist about a year and a half ago, probably 2 years ago, because I had another oncologist, and I said to her, it's about time. I'm 40 now, and I'm already at the time frame of you telling me that this is how long I have to stay on my medication. I may be single, but I should still be able to try and figure it out. So she procrastinated, and it pushed me into 40. Actually was already 40 at the time, and I started looking up just grants that I could get because I'm single, and I knew how expensive just doing the freezing alone was, and the fact that I'm paying storage on these eggs as well. And I'm looking around like wild goose chase. One, how many grants are ageist. So as soon as you hit 40, it's like, yeah, you don't work for us. And I'm like, so what happens after? There has to be more women that are in their 40s after, because they may have gotten breast cancer in their 30s and aren't able to come off their medication until they're in their 40s. So what happens to them? They're not given that same advantage of having grants that are out there for them in order to get help for IVF. And a lot of clinics still don't take my insurance, so I can't even get in the door to go to a fertility clinic, because the clinic that I used to go to, my doctor moved on to another facility. And even when I tried to follow him to the other facility just to find out what my baseline is and where I'm at to find out what I can do, they told me it's $500 just to see him.
Wow.
And I said, if I am on the insurance that I am on, do you think I have $500 to go do that? Don't get me wrong. I can probably muster up enough money to get everything else done, but adding $500 on top of it for you to tell me that I potentially have no chance in hell, excuse me, is a little bit ridiculous. And they're like, oh, we can bump it down to like 350. And I'm like, you still realize that that's a lot of money to just go in the door for you to kind of give me an idea. So I'm still in the process as a 42-year-old woman and my medical oncologist is very snarky with me because I refuse to go back on my medication. She's like, why don't you? And I said, because you know what? It doesn't make me feel good. And two, I came off of it in order to pursue becoming a mother, and nobody has any resources. The nurse navigator has no information. The oncologist has no information. My GYN has no information. In this whole health system, not one person understands how to help a woman that is in her 40s be able to become pregnant. I have eggs already. It's not like I'm trying to use the non-existing eggs that because everyone wants to tell me that now I'm menopause and everything's shut down. I'm like, but I do have eggs. I do have something that's out there. I still have some hope, and I'm gonna start. And it's just very defeating because I didn't ask for this. And just because I'm single, that's another thing on top of it. And then I said, okay, maybe I'll look into adoption. But even with that, having a cancer diagnosis, it's like, so if you're not a certain amount of years out, they look at you like, well, then what happens if you adopt this child? Are you going to be able to take care of them? Are you going to die before, this child gets, a certain age? So it's just very frustrating because I know I can't be the only woman my age or even that's underinsured. There has to be options out there, and it's just like it's really disheartening because it's not even that I'm doing it for myself. I look for information so that even another woman that's behind me, you could be 39 because you just hit that mark at 39. I apologize for being emotional. It's just that there still has to be help out there, not because you have enough money does it determine whether or not I should still be able to have kids. Because if cancer didn't happen, I could have had a oops. Who knows, Or I could have been already with someone and that's how it happened. But because that option got taken off the table without me even having the decision to say what I could do, or if I was given more options to say, freeze those embryos. Even if you go do donor sperm and then you have something that you physically have that's the eggs, they're there, yes, but now there's another factor into it because now will these eggs that have been there for that long actually become embryos if I do get donor sperm? So there's so much into it, and it's I'm sorry that I'm talking for so long. It's just that I know I'm not the only one, and I'm on the hunt for, and I probably have been in every IVF fertility clinics inbox and like looking through their page and calling and finding out what they take, who they talked, like who can give me information, but everyone gives that vague, well, we got to talk to you, we got to see your blood work. And I said, that's the problem. I can't get my foot in your door. And if I can't get my foot in the door, how am I going to even get past that? That's it.
So, no apologies for being emotional. And honestly, not like as we're leading this webinar, as your friend, I had no idea how complex or how complicated this has been for you personally. So, let's connect. Let's figure out something because I feel like we can figure out. And then once we get you figured out, we figure out how to help more women that are in this predicament because it's not fair. There's, like you said, this isn't something that we asked for. But again, I think this is why it's important that we share what we're going through because I had no idea, but now I know Tamara's probably Googling I know I want to help. I know people that want to help. And let's connect and we figure out what we can do because this isn't right.
Yeah.
Now, Christina, you have struggled with fertility after cancer. Well, before we segue, Dr. Jones, just because someone goes through hormone therapy and goes chemo does not mean that they absolutely will not be able to have kids, correct?
That's correct. And so, I know some of the testing can be expensive. Fertility doctors and subspecialist appointments with us can be expensive. There are ways. So, for instance, an OB-GYN can order testing, right, to look at someone's ovarian reserve, AMH levels, and I do this all the time with my patients. I mean, I am so cognizant of money. I didn't grow up with money. I know, like everything cost and shouldn't cost like the amount that it does cost. So luckily there are ways to navigate the system. And I'm like, how we going to work the system because it's always trying to work us, right? So for my patients who they're not in network with insurance, where your OB-GYN's in network, let me just tell her what to order. She can order it. It's going to be in network with her. There are places like Modern Fertility that you just mail in your blood. And, it's like $149 and you can get those tests much less than the 500, 350, that you just have to, this is what we do. We got to find ways to navigate it and then write that path so the next person behind you can navigate it easily. It is what it is. And I hate that it's like this, but when we find a way to finesse, we finesse. That's just, that's what it is. But, so no, you're not definitely going to be infertile. But chemotherapy is designed to attack cells that rapidly divide, that rapidly grow. It can attack our ovaries. It can lead us there, and even the eggs that are there can potentially be damaged because of the way that chemotherapy drugs work. And just because you get a period after having chemotherapies, it doesn't necessarily mean your fertility will be all the way restored. But the younger you are when you have chemotherapy, the more likely that your ovarian reserve will be spared in some ways or another. So that's kind of what it is as far as fertility after chemotherapy.
Now, Christina, can you share with us the challenges that you faced with fertility after treatment?
Yes. Excuse me. Shawnee has me all primed to cry. No, don't worry. I have not that different of an experience. I struggled with fertility before I had cancer, and it took me 3 years and some intervention to have my son. And I've always wanted a really big family, and I am 38 now, so I'm also nearing that 40 point. And when I got diagnosed, my oncologist, when I asked about, what when can I have kids? What's, what are my choices here? She basically told me that I just needed to be happy that I have a son.
Wow.
And I am. And I don't like being told that I'm being ungrateful, because I'm very grateful. But it was so callous. And so it was a kind nurse who told me to go back to my fertility clinic, which insurance does not cover. But I got Livestrong, I got Walgreens. I'm lucky to have a partner, so we were able to freeze one embryo. That's what we got. We got one. And so it was so fast. Like, I had to stop working. I'm a teacher, and I was writing, sub plans. I was trying to figure out how to do all of this. In the meantime, just devastated, because we literally decided to start trying for our second kid 2 weeks before I got diagnosed. So it was like, everything was frantic, right? Just like Shawnee was sharing. And so now here I am I'm still doing hormone treatment, but I'm in a similar position where I want to know, like, I'm 38 now, like, where do I go with this? I have one embryo. Like, what chances do I take with that? What chances don't I take? Nobody can give me a straight answer, because my cancer is ER positive, is estrogen receptor positive. I don't even know what risk I will take to get pregnant. My mother doesn't want me to. I mean, there's just so many factors. So we started looking into surrogacy, because, we thought, well, maybe that's an option. And it's very expensive. Mm-hmm. When I started looking in, so first of all, my insurance didn't cover my my embryo, that whole retrieval process. So we ended up spending $11,000 on our one embryo. And I'm comfortable sharing that just because I think people need to know that every place is different, and I wish I had done some research. We have great insurance, actually. We're very lucky. But it's rare that insurance covers these things. And we still got Livestrong, we got Walgreens, and I got one, and they said, well, we could do another. And I said, with what money?
Right.
I had to borrow from my parents for that. I don't, and I'm privileged that I was able to do that. Like, I can't do that again. So when I started looking at surrogacy and agencies and adding up the costs, and I was looking at like $100,000. Wow. Work through an agency to, pay the medical fees, pay the lawyer fees. And then we thought, well, maybe I have a friend we're so close, she offered to do it. Well, maybe she can do it. Well, then somebody said, well, you got to look into surrogacy law. If she's never had a live birth, she can't carry your kid. So I have a willing friend who is so close. I mean, she is family. I would be honored for her to carry my child, and she's never had a child, so she can't. I can't even take that chance. So adoption is very expensive. Also, I mean, it really can be. I'd be happy to adopt. We've talked about foster to adopt, which is still on the table for us, but it is a big undertaking. We've had friends who've done it. And I always wanted to foster. I mean, I imagined, oh, sorry for that noise, a huge family. So I was thinking foster kids. And so we finally decided. We've been making hard decisions because I was diagnosed in 2019. So for about 2 years solid, we've been making hard decisions and expensive decisions. And we're taking a break from making decisions right now. But I feel that pressure, that it's not societal. It's me. It's what I want. It's my dream that was taken away from me. Mm-hmm. That I didn't choose, like we're all saying. And I don't know where to go. Just like Shawnee, I don't know where to go. Who has the answers? My oncologist blows me off. The fertility clinic is expensive. Nobody can give me a straight answer. And so, I mean, now I'm just looking at what risk am I willing to take? So that's been my experience of researching and trying to figure out and I don't have an answer. I mean, I have one embryo and a lot of hope.
What I feel like we are unearthing is probably a bigger advocacy issue. Because I guarantee you ladies are two of tens of thousands of women that are hitting roadblocks. And if there are any advocates on there, like, obviously we're always happy to have conversations, but we're looking at what's it like to navigate care as an older patient, able to have people that are willing to give you information or to take you seriously. And two, we're looking at how often cost is a deterrent for us. Like when Shani said it's $500 to do this thing, I thought about the time like I was having some chest discomfort and they told me my insurance wasn't going to cover it, and I had to think like, oh, it's 500. Do I really need it? We shouldn't have to make decisions like that. We should not have to make decisions like that. So ladies, our retreat in a couple of weeks. We are the mountain movers, right? We are in this position for a reason. I really want us to think about how we can use our platform, how we can use our space and our resources to not only help you ladies navigate. So we need to make connections for you personally. Let's do that. But then as a community, how do we help the women in our community navigate this? Because we can do better. And I'm also proud that we got Live Strong on here, and so many of you ladies have used them. It's like, pick the right one.
We were so helpful and wonderful. And I'm really sorry, but I have to go. I have to feed my.
Oh, good. I know we're running late. Run away. Thank you so much.
Okay, bye.
Now, next I want to bring up, and we're going to wrap this up really soon, guys. We're so sorry we're running behind. But I want to bring on Greta. And Greta is someone that I met through the Young Survival Coalition. She's here in Jacksonville, here with me. And I love Greta, and I haven't seen Greta in a long time. So, Greta, it's so great to see you.
It's been over a year.
But when we talk about it has been. When we talk about like options being taken from us or like options not working from us, like we were following Greta during this process of adoption, and right when you were getting ready to give up.
Yep.
Let's talk about your journey.
Well, I just want to say that this is amazing. I wish I had this when I was going through this. So like I was diagnosed, it's going to be 15 years next month. So 15 years ago, as soon as I was given the diagnosis, immediately it was, you're young, you're 27, and as long as you get your cycle back, you're good to go. So we're not going to even think about going through fertility or anything like that. Because one of my questions was, am I going to be able to have children? And it was kind of just blown off. And even though I love my oncologist, or at the time, it was just very hard to hear because I wanted a family and I wanted to know what were my options. But as soon as he said, don't worry, as soon as you get your cycle back, you'll be fine. And I counted on that. And at that time, I was in a relationship, but it wasn't anything that was going to go very far. And eventually we broke up, and I ended up meeting my husband way later in life. So 5 years ago, we've been married already 5 years, and he's older. He's 10 years older than me. So I'm already at that age of, you're hitting a wall. Like you're not going to, your chances of becoming pregnant now are slim. And I just kept hearing that from my gynecologist, and it was just like, well, we can try IUIs. And I was nervous about trying anything because at the end of the day, I was just afraid of getting cancer again. I mean, that was my biggest fear, and I didn't know what to do about it. So we tried IUI cycles. I think we tried like 4 or 5, and nothing happened. We finally checked to see what my egg reserve was, and it was very low. And he said, this is a lot lower for somebody your age. And immediately I felt bad. I didn't pick this. It was very like hard because, you know, we wanted to have children and we wanted to do this, and we were ready for it. But to hear that, I was so angry at it. Like, this cancer took it away from me. But we remained prayerful. We looked into our options, and I wasn't ready to physically, I just didn't feel like, and mentally and emotionally, that I could go through the process of, you know, doing IVF or anything like that, because I was scared. I mean, it was one of those things that when I went for my oncology visit for my annual appointment and I told him what I had been doing, he was just like, well, I'm glad you stopped that. And immediately I was just like, God, okay, like maybe I shouldn't have been doing this to begin with. So it was very nerve-wracking, but you know, we started to look at our options, and adoption was one of those that we thought about it and we prayed about it long and hard. My husband was always on the fence about it a little bit, because I mean, I think it's harder for men to come around. But we, you know, we like submitted our application. We did a whole process. We went through the home study, and you know, it was just, I think it took like 2 years or a year and a half, and we didn't hear anything. And I was just like, you know, we just renewed our home study. I don't think it's going to happen. I was nervous about the application because I said I'm going to have to list that I had breast cancer, because they ask for a whole like write up on your health history. And I remember her saying, well, you know, you've been out long enough that I think it won't be an issue, and your doctor signed off on it, so I think we should be okay. But that was also a part of the thought process, like, you know, what if? I mean, so eventually we got that call right when I said, I'm throwing in the towel, it's not going to happen. And sure enough, we had our little baby boy the next day. It was that quick. It was one of those, we got a phone call one day and then the next day it happened. But
Do you have a picture, Greta? Do you have a picture with you?
Not well on my phone.
On your phone? Let's see. So, like, guys, Greta was coming to the group, and we'd be like, "How's it going? How's it going?" That's probably horrible, but we would all go through our cancer stuff.
I don't know if you could see it.
Yes, we can, and he's adorable, and I want them to see that he's adorable. And I also wanted them to realize, like, you guys were like ready to give up. It's like,
yeah.
And then next thing we know, Greta pops up with a baby on our timelines, and we're freaking out. So I think it was important for us to include Greta in this conversation, because one, I don't know how often we talk about adoption as being an option for women of color. Mm-hmm. And you guys were waited a while. You wanted a baby. You guys got a baby, and that's one of the things you wait a while for. Mm-hmm. What was the agency that you went through? Was it a local agency?
So at first we went through Catholic Charities.
That's what I was going to get.
And then we went through Adoption Authority. So, and that's where we like finally opened up to, and they like called right away. You know, a lot of things went into that thought process because of finances. Like it's expensive. It is so expensive. What happened right before we went to Adoption Authority was that I found out through my job, which I'm very blessed to have, that they actually provided a significant amount of money for fertility and fertility treatment. So that money could have been used for anything. So when I got that notification at work, that email, immediately I was like, oh my gosh, this opens up more doors for me, like, and for us, because we had been waiting. And for us, it was just like, we're getting older and we were afraid of how much longer can we wait to become parents and to have this happen. And we would have been okay regardless. I have faith in that, but we're even more blessed now, and you know, we wouldn't have it any other way. So yeah.
Well, thank you, Greta. I'm thankful to know you, and I'm glad you were able to share your perspective, and it's much needed. Now, this other perspective, last but certainly not least, we have Melissa Davis. Melissa Davis is an NBC baddie, and she wrote a blog for us. And I think it was something along the lines as like, as long as I'm living, basically. And Melissa chose to continue building her family despite her diagnosis. So, Melissa, I want to know what that thought process has been like for you and what your experience has been like. We can't really say like after treatment, but after your diagnosis.
Well, much like the other women, it was hard in the beginning because all I knew was that they said I had cancer, and I just thought my life was over and I was going to die. So I was so frightened. I just wanted it out. I just wanted the cancer to be gone. So I didn't think about fertility or any of it until after the fact that they said, and this is my busybody moving my camera, after the fact of them saying I have third stage breast cancer, I was frightened and I thought it was over. So fertility, like I said, wasn't an option in my mind because I was single at the time. And yes, I was a mother already, but I didn't think I would have the chances of having another child. So later, when I found out about the type of medicine treatment that I had to get, they said I need to move forward and I need to hurry up and continue this process because the cancer was aggressive and that it was moving pretty quickly. So I didn't have the option to do fertility, and the doctor said if I tried to do that, it would basically prolong my chances of living. So I just went with proceeding with treatment instead of thinking about fertility or any of it. But then I thought about it a little while after, not too long after I started treatment. And I said, I don't want to do this. I want to have another child. I want to get that option to have another baby. But by the time that I decided that, it was too late because the program Livestrong, they weren't offering me to have that specific medicine to get that treatment after the fact. So I was in a rock and a hard place. I would have to pay out of pocket for those services. I didn't have that money. And I knew that I couldn't provide that. So I just continued with treatment. And being that I was 30 years old, I just thought I probably would never have a child because the cancer treatment is so severe, it may damage me and I may potentially never have that option or even get a period again. My doctor said I may not ever have a period again after this particular treatment. So I just proceeded with my life. And it really hurt me at that time, being 30 and not being able to conceive again. All I could think of is I wanted to have a little girl or just another little baby, and I will never get the opportunity. And some people may think like, oh, she's just being a complainer or it's not that serious. But this was my life. I wanted to have another child. And I didn't have the chance or the opportunity to go with the fertility clinic. So I just thought maybe I just won't think about it anymore. Maybe I just erase it out of my mind because I'm never going to have a child. So then later I find out my sister's pregnant with the little girl. And I felt like that was the blessing in that she conceived a little girl, and that was my goddaughter at the time. But then it was cute, and I loved the fact that my niece was here, but it still wasn't my child. I wanted my own little girl, and I would never have that opportunity again. And even though I know my sister was so happy to be able to give me that joy, it still wasn't my joy. So I I was really, really hurt when I found out I had stage 4 at 34. It returned 4 years later. And so I'm thinking at this point, I'm single. I still don't have the person in my life that I want to be with, but I do have a period and I may have the option to have another child, but it's just not going to happen. So for about 2 years later, I found out that I was pregnant. And mastectomy because I was on treatment. And the particular treatment, I wasn't able to have a child. So I knew it would be damaging to this unborn child. But I just really wanted to have my child. And so when the doctors found out that I was pregnant, they told me, terminate. You have stage 4. You could potentially not be here if you decide to have this child. And all they kept telling me was abort. But in my mind, I knew that's not what God had for me. He said, no, this is your blessing. You're going to keep this child. And every single doctor that asked me to terminate and abort, I said, no, no, I will not. I'm not going to terminate. I'm keeping my child. And they were like, I don't know if this is good for you because you have stage 4. And you know that if you have this child, you could potentially not be here. And we don't want to make a decision for it to be you or that child. And I said, I'm keeping him. I'm keeping the baby because I didn't know what I was having, whether boy or girl at that point. And I said, I'm keeping the child. So then they set me up with a cancer specialist that deals particularly with women that have breast cancer or any type of cancer. And she was a great doctor. She said, your medicine could potentially, and your scans could potentially damage your unborn child. Do you want to proceed? I said, yes, I want to proceed. So they did all these different tests, PET scans and all these different, no, actually I couldn't get a PET scan, I had to get an MRI. And it showed that the baby was fine. And she asked me again, do I want to abort this child? And I said, no. And I proceeded. And now my blessing is here and he's 1 year old. And I'm so thankful to God that I kept him. Because I could have just said no. But I chose to keep him. And the doctor that asked me to get rid of my child, he was so shocked. He couldn't believe this baby was born through cancer. This precious little baby boy was born through stage 4 breast cancer, and I survived with no medication for a whole year. 9 months plus 6 months. Because the 9 months I was pregnant and the 6 months that I breastfed him with one boob that I didn't decide to do a mastectomy. Because my mom said, don't do a double mastectomy. And you know how we listen to our parents and the people in our family. And I'm so thankful I listened to her because I got the opportunity. I got the opportunity to breastfeed my child for 6 months. And then my cancer came back again. And I had to start treatment again. But I'm still thankful that I got the opportunity to give him the blessing of breastfeeding. And even after all that I went through.
Yeah, you have an amazing story. I remember when I read your blog and I was just like, and then after you had your son a couple of months later, I was just like, this is amazing. So I'm happy for you.
And really, like, the reason that we wanted to share all these different perspectives is one, because we know that these women are representing all of you that are watching. And it's so important for people to see other women that look like them navigate these experiences. And the moral of the story is, as you are making your treatment decisions, you keep your eye on what you want your life to look like afterwards, and you make the best decision for yourself and for your family. You take a beat to get the information and to make informed decisions, but you keep your vision of what you want your life to be afterwards. And I don't know. I think all of you are absolutely amazing. And I'm so thankful that all of you took the time tonight. KK, Dr. Jones, even though we're running over like an hour, we're so sorry. But we're just so appreciative of you ladies, your vulnerability, your honesty, your authenticity. of sharing your hearts with us and your hope with us as well. Because I think that's also very important when all of this is going on, to see that there is some hope in this. And I don't know, I just appreciate the time that you ladies have spent with us tonight.
Yes, thank you so much. It's just hearing how each of you have advocated in your own way and are still advocating, definitely will give Jasmine and I ideas on how we can further some of the work that we're doing and bring you in to help us further the work. So thank you so much. We appreciate it.
So before we log off, this is our last segment of the night. I'd like to give all of you a chance to whether you would like to give words of encouragement or advice regarding fertility, or resources. So KK, I will start with you. Any advice that you would give women if they are thinking about applying for Live Strong, or things that they might want to keep in mind?
Yeah, I would say that we have a lot of great educational resources on our website that actually walk women through fertility risk as well as their fertility options. And I'm happy to share those resources with you, Jasmine, after this call so we can get them out to the group. We also recognize that the Live Strong program fills a particular lane, but we heard about a lot of different options tonight. You know, we heard about adoption, we heard about surrogacy, and all those other things that come up with fertility. So I also have a list of other organizations that do fertility support, and I'm very excited to share that with this group too, because although our program may not be the perfect fit, there is a lot of great programs out there. So definitely, like Jasmine said, do your research, take some time. And Livestrong is a big believer in person-centered care. So do what's best for you. I think that is a really good takeaway tonight. And I appreciate everyone sharing their story.
Thank you so much, KK. We appreciate your time. I'm looking forward to sharing those resources. And again, I thank you for taking the time to come on here tonight and to be a part of this panel. It's definitely been valuable for us. And so I will, as you guys know, sign off. I'm taking you off the screen. You can run away. I'm so sorry we kept you so long. Good night, KK. Dr. Jones, any advice or words of encouragement?
Yeah, it was awesome to be a part of this discussion again this year. You know, my heart breaks for people who have kind of been crushed by the system, but I am empowered to know that there are groups like you that will take up the helm and advocate. We have to advocate. You know, if insurance isn't covering it, I mean, for breast cancer survivors, it absolutely must. You know, this is not something that was chosen. You know, it's not an elective procedure. This is the life that people choose to live. To procreate should be a choice that shouldn't be taken from you. I understand cost is a big hurdle for most people. There are resources, there are clinics that are very inexpensive. So you have to kind of do the due diligence. You have to, and once you get that, create the space where it makes it easier for other people. Resolve is a community that, really puts it like all together to help link people to get the resources they need. There are clinics. My clinic, our egg freezing cost is like $6,000. CNY in New York, their IVF is like $5,000. There are clinics that try to do what we can to help, but there are costs to egg freezing. There are costs to creating embryos that we can't all just absorb. So we need to go to our local government, to our national government, and tell them that we need this to be on the books. We need it to be so once you finish treatment, you're not going to have to, pay another $1,000 to just get your embryos transferred. It makes no sense. So, Shani, I hope you reach out to me. We can try to help you in the best way we can. I'm not sure where you're located, but I'd love to try to connect you or do whatever I can to make the dreams that you have for yourself come true. Okay. But I'm so happy to just see you guys, and I'm so glad this group exists because supporting each other is how we all get through.
Thank you. And thank you again for joining us. We were so happy to have you back again this year.
Thank you.
All right, Shawnee, words of advice, or what's the other thing I said? Girl, I'm getting tired. I'm sorry. Words of advice,
or any resources that you have.
Words of advice. Don't give up. I was at a point where I was literally just hitting a wall and I had to just stop because it was so painful. But the more I talked about it, and literally like the National Infertility Week came up last week, and I just said I couldn't stop because I don't really know, and I have to be able to find out.
Yeah.
Because that's
Yeah, you're a great advocate, and we're definitely going to make sure that we get you those resources. And now that we know that, I appreciate you sharing your story, and we're definitely, we're going to tap into you and make sure that we're there for you. So thank you so much, Shawnee, for sharing.
Thank you.
And Greta, do you have any final advice or words for everyone here? Any resources?
Just final words, just continue to be your own self-advocate. I feel like that's the one thing that was told to me when I first got diagnosed many years ago. And, it was hard then because it wasn't that common to be a young breast cancer survivor. So just continue to be your own self-advocate, continue to do the research, ask all the questions. If you're not comfortable with your team of doctors, then find one that, find a team that you are. Because in this forum that you guys have here is just such a blessing, I feel like, for everyone. And like I said, I wish this is something that I had when I was first diagnosed, because it would have been so much more helpful and informative. And so thank you guys, and I just hope everyone continues to do that too.
Yeah.
Thank you, Greta. Thank you so much. And congratulations again, you and Melissa. Congratulations. Good night.
Night.
Whew, we did it. We went over, guys. We're so sorry.
Yeah, but
so
it was
sorry.
Definitely a good conversation that needed to be had. And so I'm glad that we had all of our panelists. Like Jasmine said, thank you to everybody that came on and discussed, and everybody that stayed with us watching in the comments and asking questions and encouraging the women to share their stories. We appreciate it. Any final thoughts, Jasmine?
My wheels are turning. I just listen to issues and I think, Jesus, we've been created for a reason.
Right.
I don't know. I feel like I say all the time that our stories are not our own, and I feel like in the group so often, I don't comment a lot. I just take in a lot of stuff because I kind of feel like the space is more for other women until I'm going through something. But I'm just appreciative of how open women are, not just on this platform in such a very big way, but also in the group, because you have no idea. I don't want to get emotional, but you just have no idea how your story may spark someone else. And that's why it's so important. When we talk about being accomplices and being allies, if you're not in our community, you don't know what we're challenged with. You have to be in the community. And so I'm leaving here tonight a little sad because I didn't realize there were some challenges but more having, but then I also felt hopeful because I feel like I need to go to God now and see what can we do to make things different, make things better, because that's why we exist. We exist because we want women to make the rest of their lives the best of their lives after a breast cancer diagnosis. So it's who do we need to talk to make something shake, okay? Because this is ridiculous. But this is also why I think it's important as advocates that we are exposed to stories beyond our own. Because now I think some women in here can night and leave and be like, do you realize if I was this old, I would be having these kinds of challenges, and we should not be having that.
Right, exactly. And like I always say, when you share your story, Doesn't matter if you touch 2 people or 200 people, it still matters and it'll still make a difference.
Absolutely. So with that being said, Marissa, I forgot to tell you, I like your straight hair. With that being said, we're gonna finally log off 2.5 hours later. But thank you guys so much for spending this time with us. We hope this was awesome and informative. And we're obviously gonna send the link out afterwards. But thank you guys, and we'll see you. Yes. Oh my gosh. The next time you'll see, it's a surprise. Should we tell them?
It's a surprise. You get, nope, surprise. Surprise.
Never mind. We'll see you guys next month.
Bye.
Bye, daddies.